All right, this is again Dr. Francis. What I'm going to go through now is the surgical principles. What I'm going to do is bring together all the things that I've been trying to teach you in physiology, biochemistry, and immunology to show you that if you understand all these things together, you can bring them together to understand how to manage a patient before, during, and after surgery. My attempt here is to show students that the basic foundation of knowledge is pretty much the same as whether you know how to apply it, which means do you understand how to make new connections with the same information. So surgical principles before, during, and after. So now let's start by looking at before surgery. What should you understand? First thing you want to understand before a person is taking the surgery is the risks for mortality. You don't want to take a patient to surgery if you know they're going to end up dying during the surgery or shortly thereafter, which means you've just put them through a lot of risk for absolutely no gain. So number one risk for mortality during a surgical procedure is a myocardial infarction in the last 6 months. Why is it the last 6 months? Now remember, in inflammation, what do we talk about? Inflammation starts with swelling in the first 24 hours. Then neutrophils will saunter into the area about 4.5 hours. Do you remember when we're talking about stroke patients? Remember, you don't use TPA after 4.5 hours. Neutrophils then predominate at 24 hours and peak at day 3. Then at day 4, T cells and macrophages will show up, and they'll peak at day 7. Fibroblasts will show up at day 7, peak at 1 month, and take 3 to 6 months to scar the area completely. So therefore, until the area, especially in the heart, is completely scarred up, that means there's relative ischemia in that area, which means you put the patient at risk for arrhythmias. Remember, the number one cause of any spontaneous depolarization, including arrhythmias, is ischemia itself. What's going to happen as soon as you induce the patient with your anesthesia is that you're going to have some sympathetic drive. And once the sympathetics are released, you're going to see vasoconstriction. And that's going to make the ischemia even more pronounced and therefore set off arrhythmias. That's why a myocardial infarction in the last 6 months, do not do surgery unless it's a medical emergency. So for all of these contraindications, unless it's a medical emergency, surgical emergency rather, do not do surgery on that patient. Number two thing to worry about is heart failure. The longer you keep a patient under anesthesia, the anesthetic can depress the myocardium, which means the larger the risk of putting them into worsened heart failure. So if the patient is already in bad heart failure, then the chances are, if the procedure has to go on for a long time, that patient may not rise back off the table. So the risk of heart failure has to do with the duration of the procedure itself. Third things, arrhythmias and risk of arrhythmias. Let's say if a patient has an occult arrhythmia, let's say atrial fibrillation that comes and goes. So that means when the patient is seen, it may look okay. But if you did not do an EKG, you may not see that this person has a risk for arrhythmia or is having an arrhythmia at that very time. Number 4, occult infection. Think about it. Where would somebody have an occult infection and not even know it? Remember, occult means hidden. Where would a patient have an infection and not know it? Do you remember in low energy state? Pulmonary and urinary tract infection. Now, when you start cutting on a patient, that's going to cause stress. Even though the patient does not feel the incision, their brain is still going to feel the stress. That means you're going to release a lot of cortisol during that surgical procedure, which means during that surgical procedure, their immune system is completely suppressed, which means if they had an infection under control, it's going to get out of control during that surgical procedure, and that's why we then see infections rip-roaring and very prevalent after surgery. Next one, bleeding disorder. Well, obviously, think about this. You don't want to start cutting on a patient from sternum all the way to symphysis pubis and then suddenly ask, does he have a bleeding disorder? It'll be kind of too late at that very point because the patient is now bleeding all over the floor. You have to make sure that the patient is going to be able to clot themselves off from the bleeding before you make the first incision. Next one, severe anemia. Now notice I said severe anemia, not just anemia by itself. So watch out for that on a test question. They'll say anemia. As long as the patient is asymptomatic from anemia, there is no problem. However, if the patient has severe anemia, if you remember our discussion in biochemistry, that is a level below 6. So 6 or below equals severe anemia. That's when anemia equals hypoxia. And if you have hypoxia, again, you put them at risk for arrhythmias. Next one, uncontrolled hypertension for the exact same reason. Because uncontrolled hypertension means vasoconstriction, And vasoconstriction means ischemia, the number one risk factor for uncontrolled arrhythmias. Next one, uncontrolled seizures, for the same reason. If a patient starts having seizures, especially if it starts while they're having surgery, then there's going to be a lot of sympathetic overdrive. That sympathetic overdrive will cause vasoconstriction and ischemia again. And finally, uncontrolled diabetes. Now make sure you remember the last three are uncontrolled, because hypertension, seizures, and diabetes, as long as they're under control, they pose no excess risk to the patient. So the key is uncontrolled diabetes means vasculitis may be out of control. Vasculitis equals ischemia, and ischemia equals arrhythmias. So now these are the things that give you the most risk for mortality during surgery. So the surgeon and the primary doctor involved has to evaluate whether the surgery is absolutely necessary at that very moment, or do we have time to get these risk factors under control. Now with that in mind, now we start looking at the different factors. So first we'll look at uncontrolled diabetes. The key is to have their blood sugar as normal as possible. Why is that? If their blood sugar is low, that creates risk, because then the body doesn't have enough blood sugar to withstand the stress. The inflammatory cells don't have enough blood sugar in order to do what they're supposed to do, in fact, clean up the area of the surgery. If you have uncontrolled diabetes where the sugar is too high, so if you're hyperglycemic, that also creates risk. Why? Because hyperglycemia makes their blood a great culture medium for bacteria. And remember, after surgery, most people go to the intensive care unit. The intensive care unit has some of the meanest bacteria you'll ever want to run into. So we want that blood sugar as well controlled as possible. Now, studies have shown on the day of the surgery for diabetes, the best thing to do is to have them on IV insulin, not a sliding scale. Just put them on IV insulin, take them off all the oral drugs, and control their blood sugar that way. And therefore, it allows you to control the blood sugar as best as possible, because you can respond to the changes in their blood sugar. In myocardial infarction in the past 6 months, again, as I outlined with inflammation, you've got 6 months before the area is fully scarred up. That leaves that area relatively ischemic. Heart failure, again, has to do with the duration of the surgery. The longer the surgery goes on, the greater chance the patient will go into heart failure. So with heart failure, you want to make sure the American Heart Association classification is as low a number as possible. The higher the number, the higher the risk. So class 1 is when the patient is asymptomatic. That's obviously where we want them before we take them to surgery. Class 2 is symptomatic after moderate exertion. Class 3 is symptomatic after minimal exertion, and class 4 is symptoms at rest. So in other words, you never want to take a patient to surgery if they're already an AHA class 4, because chances are they won't make it through that surgery. Arrhythmias and risk for arrhythmias. When you do an EKG, you look for your prolonged QT interval. Some children are born with prolonged QT interval and don't even know it. Many adults develop a prolonged QT syndrome due to medication. So it's very important to take a look at that. The other way to develop is electrolyte issues, especially potassium. And so that's why we take a look at that. Remember, if you have a prolonged QT interval, it means your heart is spending way too much time in the relative refractory period, leaving a lot of sodium channels available for any ectopic site to use. So you want to rule out electrolyte problems, especially potassium, because that can prolong your QT interval. High magnesium, high calcium can prolong your QT interval. Low calcium can prolong it as well. So it's very important to check the electrolyte status of your patient before surgery. You want to check for any Q waves on the EKG. Why? Because when you have a Q wave on the EKG, it means the patient has had a heart attack in the past. It means the area is scarred, but you don't know when that MI occurred. So the key is you want to be sure it has not occurred in the last 6 months. Remember, a Q wave never disappears off the EKG. So that's why if you were to see a Q wave on the EKG, you would have that patient evaluated by the cardiologist. Let's say maybe doing an echocardiogram looking for wall motion abnormalities to try to determine how current that MI might have been. ST segment depression elevation. Remember ST segment depression we talked about in cardiac physiology? That means you got more than 70% occlusion of a vessel. That's early ischemia. That means the subendocardium of the heart is the one that's going to be receiving very little blood flow during the surgery. You don't want that to happen because that could lead to a subendocardial infarct. ST segment elevation, if you remember, means that sodium and calcium are trapped within the cell. That's more advanced ischemia. That's late ischemia, more than 90% occlusion, which means if you got that significant ischemia, then that patient is more likely to die from that ischemic event during the surgical procedure itself, so we don't take into surgery. And then another one to consider is Wolff-Parkinson-White syndrome. You want to look for that delta wave that we talked about in cardiac physiology, because if you were to see that upslope during the QRS, right before the QRS, it means this person needs to be evaluated again by the cardiologist before you're taking the surgery. So these are the factors that govern arrhythmia and risk for arrhythmias. What about occult infections? I already explained. Occult infections, you always worry about pulmonary infections and urinary tract infections. Why? Because it's part of a low energy state. Meaning, a person maybe has not been eating well in the last couple of weeks. Just by that alone, they're in a low energy state, which means infections can start developing in the lungs or in the urinary tract. And of course, during the procedure, they're going to be in a very high stressful situation. They're going to have very high cortisol levels. And if you remember the effects of cortisol, remember the mnemonic that we used before, I-KISS. Cortisol is going to inhibit phospholipase A. That's for the I. The K was kill T lymphocytes and eosinophils. So that leaves the person immunocompromised during the procedure. So you don't want them to have an infection at the very time their immune system is going to depress, because that infection will become rip-roaring and spread. And that's why the patient may die from overwhelming sepsis. The other I was inhibit macrophage migration. Well, you want the patient's macrophages to be able to come into the area to help clean up the surgical healing. S was to stabilize endothelium. So you want to be able to stabilize endothelium so you don't have as much swelling. And S was also to stabilize mast cell membranes. So in other words, if somebody is having a surgical procedure, they have a very high cortisol level, which depresses their entire immune system. Next one, bleeding disorder. Again, you don't know that somebody has a bleeding disorder unless they tell you. You may get lucky and notice some bruises on their body, but it's always better to directly ask them, do you have a bleeding disorder? Does a bleeding disorder run in your family? Are you on any medications for your blood? Because if you don't ask, some patients won't tell. And then the next one, severe anemia. As I said earlier, with severe anemia, that means a level of hemoglobin 6 or less. That equals hypoxia. And again, hypoxia then induces, or at least makes it very easy to get into an arrhythmia. Uncontrolled hypertension. Keep the blood pressure under control, because as long as you're hypertensive, your blood vessels are constricted. That means you're creating relative ischemia, which presupposes the patient to arrhythmias. Uncontrolled seizures, same thing. During the seizure, especially if they have the seizure during the surgical procedure, there's going to be some sympathetic overdrive, and that's going to cause vasoconstriction. So now, with that understanding in mind, now look how easy it is on the next slide to understand all the preoperative lab tests that we get on the patient before we take them to surgery. This way, you're not just memorizing a list out of some book. Students have a habit of just memorizing things out of books, but never making sense of it. What I'm trying to do is help you understand what it is that you do as a physician. Because once you understand what it is that you actually do as a physician, you will enjoy it more. This way, you're not just reciting words off of a page out of some book, but you actually understand why you need to do what you do. So the first one, you need to do a history and physical. Obviously, you don't take somebody to surgery if you don't give a running story about how it all started and how it came about that we need to do surgery on this patient. That is, in case somebody else comes behind you and looks at the patient. Everything has to have a context. Given the context in the history and physical, then the next person that comes along knows exactly how to evaluate the patient. And you will also know how to evaluate the patient. Next one, CBC. You do a CBC. Why? You want to look at the white count. If the white count is elevated, you got to question whether the patient has an occult infection. You take a look at the red blood cell count. Make sure they're not severely anemic. You look at the platelet count to make sure that they've got adequate platelets in order to stop the bleeding. Next one, urinalysis. Urinalysis, why are we doing that? Because we want to detect if there's any evidence of an occult urinary tract infection. The patient may not even know about it, so we do a urinalysis anyway. Chest x-ray, same reason. Remember, pulmonary infection and UTIs, top two areas of infection in somebody who has a low energy state. So the chest x-ray, we look for any infiltrates. Again, the patient can be asymptomatic, so you can't go by that. You do the chest x-ray to see if there's any infiltrates that are unresolved. You do an EKG to look for all those things that we talked about, that predispose the patient to arrhythmia. The QT interval, make sure it's not prolonged. Look for a Q wave. Look for a delta wave. Look for any ST segment elevation or depression that then allows you to evaluate this patient further before you take him to surgery. You do a PT and PTT. Why? To rule out any bleeding disorders. And then you run any of the labs according to the patient's illness. What do I mean by that? If the patient is a diabetic, then you need to do a blood sugar, but you don't have to do a blood sugar on everybody. If the patient has a history of hypothyroidism, then you want to check a TSH and so forth. So if there's other drugs that they're on, you may need to check their levels. But these are the tests that every patient should have on their chart before you take them to surgery. Now, let's look at preoperative medications. What preoperative medications do you have to give somebody? Number one is a preoperative antibiotic. The antibiotic you choose is a choice that a surgeon makes. The key is to understand what bacteria you would run into during the surgery. For instance, if you're going to be cutting the skin, you're going to run into gram positives. If you're going to be cutting into the intestines, you're going to run into gram negatives. So if you have to go through the skin to get to the intestine, you're going to run into gram positives and gram negatives. So you make a choice depending on where you're going to be cutting and what kind of bacteria you anticipate that you may run into. But preoperative antibiotics are given primarily 1 dose 1 hour prior to surgery. The reason for that is because we want the serum levels to be at its highest point during that surgery. And peak serum levels for most drugs are around 2 to 4 hours, maybe even as long as 6 hours. But at least this way you know the serum levels are rising at the same time that the patient's immune system is being depressed by your surgical procedure. Therefore, you want to make sure bacteria cannot enter their log phase, which means they cannot start replicating. Next category is the SBE prophylaxis, subacute bacterial endocarditis prophylaxis. Subacute bacterial endocarditis, if you remember our discussion on that, is caused by Streptococcus viridans. And you run into that whenever you invade mucosal surfaces, so GI, GU, and respiratory tract. Mitral valve is the most common valve involved in SBE. And you give the antibiotic if the patient has any hole in the heart or any valvular disease except mitral valve prolapse. So watch out for mitral valve prolapse because that's the one valvular disease where the risk for SBE was found to be exactly the same as the general population. So you do not have to do prophylaxis if somebody has mitral valve prolapse without any evidence of regurgitation. Now, if they have regurgitation, then you have to do prophylaxis because on the basis of mitral regurgitation. Now, just to give you an update on SBE prophylaxis, a lot of new information has come out of this. Somebody did a retrospective research on this in the last 20 years to see, well, who actually gets SBE during or after a surgical procedure? And they found really 3 main reasons. Number one was somebody who has uncorrected cyanotic congenital heart disease. Number 2 was somebody who still has some prosthetic agent still in their heart. And number 3 was somebody who had a previous history of SBE. However, because the literature has not been completely updated for physicians to follow this new recommendation on the exam, you still have to do prophylaxis for anybody with a valvular problem except mitral valve prolapse. Another category, anticonvulsants. The rule is for anticonvulsants, you must continue them during the procedure. You must give the last dose on the morning of that procedure so that the medication is available throughout the entire surgical procedure. You never want a patient to start having convulsions during the procedure itself. Next one, what about diabetic medications? As I said before, you discontinue any oral medications and you switch to IV insulin prior to surgery. Research has been done and found that the sliding scale was inferior to just using IV insulin to manage the patient's diabetes during and shortly after surgery. And then the next category is to minimize pulmonary secretions. Whether you're laying on your back or you're laying on your stomach, all the hours that the patient is having surgery done, pulmonary secretions are accumulating. And because they're under anesthesia, the cilia in their lung don't work too well. That means if the cilia is not working very well, you're not clearing mucus out of your lungs. That means a lot of mucus will build up. This is what then predisposes patients to pulmonary infections following the surgical procedure. So in order to minimize pulmonary secretions that can build up during the procedure itself, we give them drugs like atropine and glycopyrrolate, which are two anticholinergics. Remember, cholinergic, i.e. parasympathetic system, controls the pulmonary secretions. So anticholinergic will dry some of them out. So again, it's usually one dose given prior to surgery. Then other medications that we give to patients would be only if necessary. That means if they're hypertensive, you continue their hypertensive medication. If they're hypothyroid, you give them the thyroid medication. So any medication that's still necessary, you must give. But the rule is the last dose of that medication must be given on the morning of the surgery with only sips of water. This is usually visualized by the nurse. Why? Because the patient has been NPO, nothing by mouth, for more than 6 hours, and we want that stomach as empty as possible. If the nurse were not watching, the patient may drink a lot of water or a lot of juice with their pills, and now with a full stomach, you cannot do the surgical procedure. Or if nobody caught it, then the patient is at risk for large volume aspiration. So we don't take that chance.